emotional intelligence. Surely today we will see our true version of ourselves in the mirror. So moving ahead to the other speaker, we have too many sounding words and too few actions that corresponds with them. A man whose actions speak louder than the words has privileged to take our country on second machine age and named as first established robotic surgeon of Pakistan in public sector hospital, and has completed around millennial number of cases on CMR versus. He is none other than our Professor Rehan Mohsin. Professor Rehan is serving as the Professor of Urology at SIUT. His areas of experts are urology and the laparoscopy and robotic, and also uro-oncology. He is our national pride, who has truly revolutionized the thought of robots cannot survive in underprivileged countries into robots can survive even in unforgiving environment of politics, hunger, and war. Let me have the honor to invite him for the talk on robots in surgery, industry-driven toy versus surgeon's companion. Dr. Rehan, sir, please be on the stage. We would like to be here. Thank you so much.
Thank you very much. And it's a great feeling for me, and I am very much privileged that I am a part of this meeting. Being a urologist, I always consider myself as half surgeon because we urologists always deal with the retro part, which is half of the body. So you can say me that I am still learning the surgery. So quickly on my topic, so I have nothing to disclose. So changing gears to surgery, directly onto my topic. So we all know that why the laparoscopy became popular at that time, because of the minimally invasive nature of laparoscopy. And we all know that because of laparoscopy, there are smaller incisions, less infection, less blood transfusion, and patient can go home very quickly. But the problem with laparoscopy is this, that though it is minimally invasive, but it is maximally demanding. The learning curve is very steep. I can say this like this, that if we make two groups, one for laparoscopic surgeon and for robotic surgeon, so out of 10, probably 3 or 4 laparoscopic surgeon may have enough expertise to do surgery in a very successful way, while for those who are in robotic group, maybe 6 or 7 may have enough expertise level to perform that type of surgery. And the other problem with laparoscopy is this, that it actually strains the surgeon. And it is my personal experience that when I was doing laparoscopic donor nephrectomy on a very routine basis, I did experience a very constant and very boring sort of pain in my right arm, because I had to use that part of my muscle daily, and because of that pain, I had to take a break from laparoscopy, and I had to take an advice from the orthopedic surgeon, and I had to go through some physiotherapy treatment, and I had to quit that donor nephrectomy for quite some time. So this is one of the problems with laparoscopy. One can say that from the shadow of laparoscopy actually emerged the robotics, and this is very true, because in robotics, the principle is always same, because there is a laparoscopy, the vision, it's not like that. You don't have the liberty of feeling the tissue, and many things are like with laparoscopy. So what were the conceptual basis of the start of robotic surgery? So it was actually the NASA people who first thought that this should be done especially for those astronauts who worked in the space, and they also have, at that time, it was probably in the 80s, that they have the facility of having telepresence, 3D virtual environment, telemanipulation, etc. and etc. So actually NASA people gave this concept, but before NASA could do anything, it was the engineers from who were working down at the Earth, and they first made the robot, and probably it was in the 1980s when the first robot did its work, like it was the Puma who did a brain biopsy. But since then, a lot of evolution had been done in the like Zeus, Aesop, and then comes the time of Da Vinci. First it was S, then SI, then XI, then single port, and so on and on and on. And currently there are so many robots are working in clinical practices. And the greatest thing of the robot is this, that the learning curve is very short. And it's not necessary that the surgeon should have laparoscopic experience. So those who are expert in open surgery can also do robotic surgery, and the learning curve is very short. So why surgical robot is necessary? Because the robotic system provides 7 degrees of freedom, which our hands cannot do. And the 360-degree, rather than more than this, is available to do surgery, especially in those parts of the body in which the human hands can't work, especially in the pelvis, like when we do radical prostatectomy. And in open surgery, being a surgeon, you people must know that the vericourethral anastomosis is one of the most difficult part of that surgery while doing by open technique. But if I do it by robot, it is just a matter of few minutes, then I could complete that part of the surgery. And these are actually the magics, and this instrument can give the different rotation, the different movements, and because of this one can do the surgery with great ease. So what is robotic surgery? Actually, it is a machine, it is a computerized programmed machine, but the important thing about this, it is actually a master and slave relationship. So whatever you do on the console, it would be executed in the body. If you do a right thing, then the robot will do the right thing. So if any case there is any complication, it doesn't mean that the culprit is robot, rather the surgeon is the culprit. So these are the advantages. The majority of the advantages are of those of minimally invasive surgery. And again, the keyhole incisions, there are less doctors are available, less assistants are required. The patient can go home early. If you talk about the oncological control, the result says that the cancer control and the patient survival rate is almost equal. And because of the popularity and the great ease of the robotic surgery, because of its 7 degrees of movement and other advantages, this robotic surgery application has been adopted by almost every discipline of the surgery. And as a urologist, I can say that anything which can be done by open technique can be done by robotics. And especially it is very, very helpful when I do pelvic surgeries like prostatectomies and radical cystectomies. So because of the greatest advantages of the robot and because of the millions of surgeries had been done on the robot, we can say that there had been a standardization of the surgical procedures. Many procedures can be said that it is to be done, then it is a standard of care procedure like partial nephrectomies, radical cystectomies, etc. And if we talk about the gold standard procedure by robots, then the radical prostatectomy is definitely one of the gold standard procedure by the robot. But the condition is this, that this applies for those centers which actually has the robot in their surgical facility. So there are multiple surgical robots which are available in clinical practice, both like European, American, as well as the Chinese have also entered into the market. And if we see the global picture of the robotic installation, we can see that approximately, rather more than 9,000 robotic units are being utilized globally. And now you can see that because of the great popularity of the robotic surgery, the open surgery graph is going down while the robotic surgery graph is going up. And same is happening in the field of urology. So in the urology cases, the cases like partial nephrectomy, prostatectomy, cystectomies, all are gaining popularity to be done by robotics, while and the open and the laparoscopic graph is going down. And it is said that by the year 2030, uh, uh, annually there would be an increase in approximately 13% of robotic cases in the field of different disciplines of surgery. Yes, when we talk about the market shares, yes, definitely it's a costly modality, and because of this, the vendors are getting a huge amount of market shares. One can say that by year 2030, the total market share of the intuitive would reach up to $130 billion. And if we talk about the revenue generation and the profit, again, it is a multi-billion sort of profits what the robotic companies are getting. So you know that a huge amount of economics are actually available, are involved in the field of robotics. And if one want to start a robotic facility, then this is a chart which shows that a minimum of $1 million is actually required to have, which is actually the capital cost of a robot, while for annual maintenance, again, 100,000 US dollars is the minimum which is required, while the per case cost actually varies from 700 to 3,000 US dollars. So one can say that it is definitely a costly modality. That's why I label it that one of the greatest advantages of robotic surgery is its cost. But वो जो कहते हैं ना कि party तो अभी शुरू हुई है, now the Chinese have actually entered in the field of robotics. At SIUT, we are using one of the Chinese robotic, and I can tell you it is like the Da Vinci Xi. I have worked both on the Da Vinci as well as that Chinese robot, and it is almost the effective. And the other great thing is this: the cost is almost half. Not only the capital cost, but the maintenance cost and the instrument cost. So one can say that Chinese has actually broken the monopoly of the Western robots, and it has made that robots affordable and equally effective. And when currently there are only few Chinese companies which are providing these robots, but a lot of Chinese companies are working on this, and one can think that if everyone comes into the market, then probably the robotic price, the maintenance and the instrument price would definitely go down to a very affordable level, very affordable price. So why Pakistan needs surgical robots despite high cost? Because technology is relentless. It has to come and it will come. This is a very irrelevant cartoon which I picked up from the internet, that the small kid has actually invested his pocket money into the technology, and that uncle is pleading to that kid that where I should go and where I should, he actually also want to invest in the same technology. So let's talk about the robotics engine in Pakistan. It was started way back in 2011 at Sindh Government Hospital, Qatar, and after 2 years, there was installation at Civil Hospital, Karachi as well. And if we talk about the urology, we actually lagged behind. As a urologist, I can admit that we lagged behind 2 decades in order to adopt this type of technology. As you can see, the first robotic prostatectomy was performed in the 2000, while in Pakistan it was done in after 19 years. So we were very far behind. And if we further compare the regional disparities, again, the situation is very grim. If we talk about the India, which is our neighbor, there are more than 100 robots are working, while in Pakistan, hardly 8 robots or 10 robots working. While in India, there are more than 500 surgeons are trained enough to perform robotic surgery, while in Pakistan, there are just handful of the surgeons who can do this type of surgery. And again, the India and the Iran, we both are our neighbors, and they have made their own robot. Even the Indian robot, Mantra, is also being used clinically, and they have launched this robot. So where I work, SIUT, it is one of the largest tertiary care hospital, and our motto is this, that we treat our patient free with dignity, irrespective of caste, color, creed, and religion. And we also think that it is our primary responsibility that we should also provide this type of treatment to our patient population. And in urology, there are many diseases which should be treated by robot. So we started our robotic program in the partnership with Civil Hospital Karachi. And we performed first robotic surgery in the year 2017. And one can see that Professor Rizvi was also the part of this surgery. And on that robot, we have done more than 650 cases. But because of logistic issues, we had to take our patient to Civil Hospital Karachi, and there were multiple problems. So we actually required our own program because our waiting list was very long. So we managed to start our dedicated robotic program, and the inauguration was in the year 2021, and the theater is in the transplant tower of SIUT. And on that system, we have actually 2 robots, and which works from 8 to 7 or 8 when we work in the late hours also. So it's the data between 2021 to 24, and we had performed approximately 1,800 cases. So this is a ladder of a complexity, what we have learned from our experience, that it started from simple nephrectomy, then we switched to some more complicated cases, then more complicated, and then more complicated. So currently, we are doing radical cystectomies, which is thought to be one of the most difficult procedure to be done by robot, but we are doing it very successfully. So the AI has been very well discussed by my previous colleague, Dr. Shams, and definitely when the AI would be integrated with this robot, then more magic will happen. It will help in pre-operative planning, per-operative guidance, and also in post-operative predictions. So one of the greatest disadvantage what that tool has, what can say that what that toy has done it very successfully is the telesurgery. Very recently, a transcontinental robotic partial nephrectomy was done where the surgeon was in the France and the patient was in the China. So because of the utilization of 5G, 6G, 7G, and the advancement in internet, these can also be possible. And even the NASA, what they thought in the year 1980s, now they have done another experiment in which the team was in the Nebraska Space Center, and the robot was in the International Space Station, and they did perform some of the knotting and tying. So the time is probably reaching soon that then the surgery would be placed in the international space by the robot when the surgeon would not be available there. So I can say that initially what thought to be a toy has become a very smart and very effective tool. And I would like to conclude that it is actually the journey from toy to trust. Initial launch was 2000s, and it became a clinical realization in the year 2010 and onward. Then it became a standard of care for certain diseases, for certain surgeries from 2020s and beyond. So what began as innovation has now become indispensable. So I always conclude my presentation with this slide that Professor Rizvi always says that we cannot let them die just because they cannot afford to live. And I am lucky that I am a part of his team, and I am also providing robotic surgical treatment to those patients who cannot afford it. Thank you very much.
Thank you, sir. Thank you for giving us robotic insights and giving us a toy and developing us trust over the toy. So let me call upon my teacher, mentor, and the brain of our Scientific Session Society of Surgicon 2025, Professor Masoom Mirza, who is serving as the head of department at Hamdard University Hospital, to give token of appreciation to our distinguished plenary guests and speakers. Professor Masoom Mirza, sir.
Anyway, well, it was not in script, Munira. Anyway, I appreciate and welcome and thank you all the panelists here in this session. And what I would say, is there any question from the audience to the panelists? You can raise the question and they will respond to that.
Any questions? Yeah. Yes, Professor Shafi. Mic, please.
Now, I just wanted to ask Professor Rehan, talking about robotic surgery. We have acquired some CMR now after Evency, and but the Chinese are coming up. How do you compare CMR with the Cambridge University robot with the Chinese robot? Because cost is a constraint, Evency is too expensive to maintain, and Chinese is right by our side.
Yes. So these are two entirely different systems. Though the CMR versus is actually in this, it's a modular sort of robotic system in which there are multiple BSUs. While the Chinese robot, on which I am working, that is an edge multi-port robot. It's like Da Vinci, in which a single cart with multiple robotic arms. On CMR, we have done approximately 1,700 cases, and it seems to be a very good modality. We do work on that robot with quite comfortably. But as you asked, that what is the difference between? I think it's like the end result is the same, but it's like that you drive two different cars, like you drive Honda or Toyota. So these are two different systems, but the end results are same.
Right. Professor Majeed Sahab, may I present you the token of appreciation? As
There's a question. Yes, question? Yes, sir. No problem. Professor Channa?
You just presented a very good elaboration of a technical aspect of the robot. But in the base of these things is a AI, artificial intelligence. And this thing, art, the future is of the autonomous. What do you think about that with this artificial intelligence, how far they will go, and what will be, as you rightly said, that it has become a tool and the master and AI development, they are becoming the masters in a way. So what do you suggest about it?
Okay. So currently, what the robot which we are using at the autonomy 0 or 1, but people are working that this autonomy should go up to 1, 2, 3, or even to 5 level. So probably the time will definitely come when then we have to program the robot, and the robot will do the rest. But it's not the time. Probably it may take 5, 10, or maybe 20 years. As I said in my presentation, that the NASA people have done an experiment which they actually started doing that work since 1980s. But very recently, they have succeeded to do this type of even very small motions. The other part of your question is what would be the ethical consideration. So it's very difficult. I think when the time will come, I think the society will accept it, and maybe some ethical board or ethical committees will definitely look into this matter, and they will allow that modality, that it would be a part of standard treatment.
Thank you.
any other question from audience? No. Right. Professor Majeed Saab, since you graced this occasion of Surgicon 2025, may I give you a shield as a token of appreciation, please?
Center. Ladies and gentlemen, I want a thunderous and prolonged applause for Professor Majeed Chaudhary. Prolonged. You should keep on. Please show your enthusiasm. Thank you, Professor Chaudhary. It's lovely to be here.
Now, Professor Shams Nadeem Alam, who talked about the artificial intelligence. Hopefully, it will be real intelligence in future.
Thank you. Thank you, sir. Ladies and gentlemen, please welcome him with a round of applause. Big round of applause. Thank you so much. Thank you, Professor Shams.
Dr. Rehan Mohsin Saab, thank you delivering a talk on a trusted toy, the robot.
Thank you, Dr. Rehan. Dr. Rehan, here, Professor Rehan is really a benchmarker for our junior surgeons. So give him a big round of applause, ladies and gentlemen. It has to be continuous, prolonged, thunderous. With that, we have concluded our plenary session for the Surgicon Day 1, 2025. Moving ahead, so for the break, tea break, sir. Okay, so we serve the tea in outside, whole egg.